So this session is primarily intended for the postgraduates. So an ophthalmology resident is assumed to be confident in the basic surgery, that is SACS, by end of their residency. However, because of the surgical skill acquisition requires extensive supervised hands-on training and practice, it is somehow missed, and even after their residency, they are not able to do even SACS confidently. Moreover, the delicate nature of the ocular tissue and the small scale of the eye's anatomical components results in a low tolerance of error. Also, the lack of consensus and strict guidelines for surgical training in India results in wide variation in the surgical competency among residents. So, today we'll be discussing on how to achieve and learn the maximum from the minimum cases they get, and also to make them aware of the ways to train themselves without even live patients with the help of simulators and wet lab. So we are beginning our first session. SSC's Basics, Knowing Your Anatomy Well, Must Read Books by Dr. Vaisakhi Prasannan.
Good morning, everybody. I am Dr. Vaisakhi Prasannan. I am currently doing Pediatric Ophthalmology Fellowship at Dr. Shroff Charity Eye Hospital, Delhi. And we'll start our presentation stressing on the fact that we should always know what we do, especially when it comes to case of surgeries. Like we already know, the eye sees what the mind knows. Similarly, we can only perform a surgery until we know the surgery very well. And hence, before starting any surgical training, we should be well read about the surgical anatomy, the steps of surgery, instrumentation, when to modify your technique regarding each step, complications to be anticipated in each step, how to identify the complications and managing it. How to learn a surgery. Textbooks and literature are the foundation stone for learning anything. Added to that, we can have classes, discussion among seniors and our peer group, videos, observation, and importantly, wet lab practice. Today, we'll be discussing few books which are essential while learning the surgical anatomy and surgical step in case of SICS. First one is Henderson's textbook on manual SICS cataract surgery. Here, this book gives an extensive review about the instruments, details of each instruments, anesthesia, step of surgery along with its diagram, how to identify complication and managing. And this book is around 185 pages, and it gives an extensive knowledge about everything you should know about SICS, and it is available in Telegram. And this textbook by Ashok Garg on small incision cataract surgery, it's a very big book, around 1000 pages, and it starts with anatomy of crystalline lens, etiology and classification of cataract, and also it gives a brief idea about how OT instruments are sterilized, anesthesia, step of surgery, and dynamics of each step are given in detail in this book. Also, it tells about the complication, recent advances, and special cases, like in case of pediatric cataract surgery also it discusses. And this is available, actually you can buy it from Amazon, and this book comes with a CD-ROM which has surgical videos also. And this is a very concise textbook containing of 30 pages by Dr. Ruji Goyal et al. And here it gives steps of e-surgery with diagram, and it's a very precise book. It's a very handy book which you can use for revising or just to brush up your knowledge about SACS. And coming to Aravind manual SICS cataract surgery manual. Here, this is one which we also had followed. It gives details about surgical instruments as well as surgical steps and complication. And this is also available as ebook online. And this is a link which you can use to get the book. Finally, YouTube has become a very accessible as well as a reliable source for learning. And this OroTube is a channel by Aravind Eye Hospital, Pondicherry, which gives detail about SICS, how to perform each step, and how to perform each special cases also. Finally, these are two books by Harvansh Lal et al. And Siebel on phacoemulsification surgery. Understanding the mechanism of each step helps in learning as well as practicing them in a better way. Also, it boosts your confidence. Knowing the dynamics make the surgery a better experience for the learner as well as a good outcome for the patient. And above all, always, rather than reading, practice makes it perfect. It's your practice that will make your surgery always perfect. Thank you.
So our next talk is by Dr. Abhisha. She'll be presenting on do it yourself at wet labs.
Good morning, everyone. Coming to my topic, wet lab training. As a resident is concerned, there exists a multipolarity at the level of ophthalmic surgical training. There are people who have done lot of surgery and they, on the other hand, not even done a single surgery. And there exists a different learning curve also for all of us. So there comes the importance of wet lab, which is a safe and standardized method for training without the risk that can come while operating on real eyes. It will make us better equipped on real eyes. We can do the same surgery without complications or failures. It can enhance the psychomotor skills, hand-eye coordination, ambidextrosity, and it will create less stressful environment. Coming for the setting of a wet lab, we should have adequate space, equipments, instrument, and should we have a proper curriculum. Ideally, the wet lab should be located within the main hospital building so that we can approach whenever we are free. And it should be spaces to accommodate at least 2 people, one trainer and a one trainee. And should be ideally 10 cross 10 feet. This is a wet lab setting in my hospital. And it should be an air-conditioned room with a refrigerator and microwave oven, an operating microscope, whiteboard with chair and table, preferably adjustable chairs, sink tap, and biomedical waste management system. Coming to equipments and instruments, at least for SICS wet lab, we should have a microscope with a side scope or camera connected to TV screen so that we can record the wet lab training and we can assess our progression. For phacoemulsification, we should have a phaco machine with tubings and expandables. Depending upon the nature and type of surgery, we have to get sutures, gloves, blades, eyes as well as fluids. Surgical instruments, minimum surgical instrument set should be available within the wet lab. And eyeball fixating devices, either in the form of mannequin or styrofoam head or eyeball fixating stands like this should be available. And we should have a design training curriculum, since as we all know, a resident is always confused on how or what to start. In our institute, after 3 months of joining, we will be having 15 days of lecture as well as wet lab practice, followed by OT surgery. We will be under one-to-one care under the guidance of a trainer for first 15 cases. Along with that, pre-operative as well as post-operative ward rounds and video discussion makes us perfect. We were advised to do suturing, which is a vital ingredient which will increase our hand-eye coordination and dexterity under microscope. We were advised to do 50 good radial sutures with proper depth and spacing using 10 nylon during the initial days. These were that I practiced. And coming to eye preparation, either we can get rejected or unfit donor cornea or eyeball from eye bank. Wax or artificial eye can be used like phaco or eye phaco, or animal eyes like goats, bulls or porcine can be available from local butchers. Coming to surgical anatomy of goat's eye, for a beginner, usually the rexis is little bit difficult in goat's eye, since the lens thickness is twice that of humans and it is a soft cortical lens, which can be used for trenching in phaco. And there is blue reflex rather than red reflex in humans. Bull's eye anatomy, the scleral thickness is more comparable with that of humans, which will make the tunnel making perfect. In porcine eye, it will the anterior lens capsule mimics pediatric ALC, which is thick, more elastic and viscous. These are few images that we usually do in our wet lab with goat's eye, peritomy, tunnel making using crescent, capsular axis. For capsular axis in our institute, we usually use a discarded IOL, opened or damaged IOL package. Like this, we'll make rounds and we can practice rexis. Phacoemulsification, coming to phaco wet lab, for the phaco dynamics as well as foot pedal adjustment, we can get well trained in wet lab. And we should have a logbook maintenance to assess the progression. And we can follow IC Oscar grading for SICS, which will be dealt detailed in later. So all residents, go get trained in wet lab. Surgery is an art as well as a learned science. Thank you.
So next session is by Dr. Anju Kyriakos, and she'll be talking on no wet labs, no issues, how to train yourself at kitchen.
Good morning to one and all present here. I'm going to talk how to convert your kitchen into a wet lab. When you don't get access to any of the things what Abhisha said, you can do this at home. Precisely 3 years back, we were in that scenario that you didn't have anything. The surgical training was totally closed. That time we were at home, locked down. So what we did during our lockdown time?
The authors have no financial interest in this presentation. The year 2020 brought a lot of
Audio.
financial interest in this presentation. The year 2020 brought a lot of surprises. The coronavirus attacked humanity. It rapidly spread across all the countries of the world. The world had to go into a lockdown. Elective surgeries reduced drastically and surgical training practically stopped. Practicing in the wet lab became even more important. Welcome to Anju's Kitchen. You can simulate the feel of a microscope by putting a smartphone between two boxes with the video mode and flash on. This gives magnification, illumination, and allows you to record your surgeries. A tomato with needle and thread can be used to practice superior rectus bridal sutures. SICS tunnel can be practiced on the boiled egg using a crescent blade, even a side port, and also a keratometry. If you have a magnifying loupe, you can use that instead of the smartphone microscope. Make a cystitome by bending a 26 gauge needle. You can practice capsulorhexis on the skin of a tomato which has been kept in the microwave for 5 to 10 seconds. You can also use that smartphone microscope simulator and an onion. Similarly, you can also do a can opener capsulotomy. Nucleus delivery can be practiced with metal wire to take out a seed or garlic, for example. If Simcoe is not available, a syringe can be connected to a tube and pick up tissue paper bits from a bowl. It would definitely be better to practice irrigation aspiration with a Simcoe cannula. Bits of tissue paper can be aspirated from any bowl. For phacoemulsification, a piece of potato can be cut out. This can be cut in the shape of a cataract nucleus and using a pencil and needle can be chopped. If available, loading of foldable IOLs can be practiced. Along with the proper injection of the IOLs. Other than cataract, trabeculectomy flap can also be practiced on the boiled egg. The incisions can be made and the flap can be raised. A cut grapes fixed on a toy can be used to practice suturing. Tomato can also be used for suturing practice. Hope this guides you to set up a wet lab in your kitchen and practice eye surgeries at home during this pandemic. Thank you.
So I hope you have an idea how to convert your kitchen into a wet lab when some situation occurs. So this video is available in YouTube for further reference. Thank you. Next topic is by Dr. Raki. She's going to talk on learn from the mistakes, how to keep a diary.
Good morning, everyone. So, I'll be talking on learning from your mistakes and how to keep track of yourself via logbook. So, my main objective is to tell you how to learn from your mistake. This can be either by reassessing your surgical steps and grading yourself with your trainer, reviewing your surgical videos and learning from your own mistakes, keeping a track of yourself via logbook, and self improvement. There are different systems of surgical proficiency, which OSCAR, OISS, and IC. I'll be detailing on them too. So, an ophthalmology resident should be confident performing the basic surgery, that is SACS, by the end of their residency. There are multiple formative assessments available for SACS to achieve the desired level of competency. However, convention in most of the institutes and colleges, they audit the surgical cases post-operatively by just assessing the visual outcome the patient has got, and they will not be assessing a stepwise regularized format for surgical performance. So if you have a toxic mentor with you, then if he passes on any discouraging comments while you're doing surgery, you lose your confidence and your chance of self-improvement. Similarly, if you have a very helping colleague and who keeps on praising your surgical skills, you become overconfident, and there also you lose your chance for self improvement. So, in order to bypass that, the International Council of Ophthalmology has created the Ophthalmological Surgical Competency Assessment Rubric, which breaks down an operation into several steps and sets clear guidelines for different level of skill in which a step has to be performed. DeFrois have come up with a stimulation-based model for skill acquisition also, which also is very valid and useful. So as a training tool, this helped the trainees to assess the surgical skill in a structured and objective way. Knowing exactly what will be assessed also help the trainee to be clear on what is expected of him or her and have lots of opportunities of self-improvise. So this is an article by Dr. Ashok Grover and Santosh Honavar sir, etc. And they have also recommended the ICO rubric system for NMC-based ophthalmological residency training. This ICO OSCAR system is available not only for cataract, it is available for strabismus, retina surgeries as well. So this is the ICO grading system. I would like to draw your attention to the point 4, that is the corneal entry in this. Here the resident is very hesitant with keratome. He is entering into the AC, but he is unable to extend the tunnel. So he is considered as a novice surgeon. However, if the resident can enter into AC, but there is difficulty with extension, he creates different planes, then he is considered as a beginner and he is given a score of 3. But if he enters at the right plane, also able to extend, but he is not able to form the AC, he is repeatedly using viscoelastic, he is considered as an advanced beginner. And if the resident is able to do everything fluently with a self-sealing wound and not using much visco, he is considered as a competent person. So this is how you will be graded. Other than steps, there are global indices like the wound neutrality, the iris protection, the overall speed and fluidity, which also will be graded. Similarly for phaco also. Now coming to the objective assessment of skill in intraocular surgery scoring system, which was developed by Harvard Medical School to assess residents' competency. The main difference is this has 3 aspects: the pre-operative, intraoperative, and the post-operative aspect. In the post-operatively, they will assess your visual outcome, astigmatism, complications that you have created, striate keratopathy, etc. Other one is IC, which is a simulated assessment tool, but it correlates well with the real life cataract surgery. Only issue is that this has a motion tracking system, so there can be individual variations with that. The next step is to learn by reviewing your own surgical videos. So try to record your initial surgeries and review them with your mentor or a senior fellow, and try to find out which steps went wrong and ask for suggestions how to overcome that. Make it a habit to rewatch, even if you think that you are a very skilled surgeon. If you keep watching on your own videos, each time you will find some fault techniques. And also, if it is always good to watch the senior surgeon's instrument handling from outside, and also the hand rest positions from outside, and learn from that. Next is logbook. This logbook is a very crucial document, especially for job interviews. and also when you're applying for international jobs or fellowships. So this has to be a binded, properly printed, signed and sealed by the director of the institute. This will act as a proper certification for the number of surgeries that you have done and proficiency in surgery. So they will know that you are not just bluffing the numbers. So this is the logbook, and you can see in the initial pages they'll give the ICO rubric. Then this is one of the entry of the patient. Here in the left you can see the patient's particulars, and this is how you'll be graded. The trainee will give a score for himself and the trainer then will grade you. After that they will give comments also. You can see here down they have, it is written, face difficulty in cracking, should learn cracking more, and this face difficulty with power modulation, etc. So you know exactly what is going on and what you have to improve. Similarly, okay, then if you don't have a logbook and if you don't want to carry it around, other thing you can do is you have to make an Excel, and you can import it into your phone itself. Nowadays all smartphone, with all smartphones you can open up Excel, and then you can just write the patient particulars, diagnosis, any preoperative problems like pseudo exfoliation if present, what surgery was done, who was your trainer, what was the IOL power, what was the difficulty faced, and soon after that you have to write the management also, like whether you have done the difficult situation, you have overcome the difficult situation, or your trainer helped, and what did he do for that. And you have to follow up the patient, and you have to enter the post of 1 week, 1 day and 1 month, as well as the spherical equivalent. So this is like your own diary, to which you can go back and learn what were your initial problems and how you overcome that. Similarly, you can make one for phaco also. So if you don't want to make your own logbook, there is this site by Royal College of Ophthalmologists where there is logbooks already there. You can just download it into your phone. This is another book by Dr. A.K. Kurana sir, which is very useful. It is a logbook book come practical manual. So to conclude, you have to learn from your mistakes. Mistakes has the power to turn you into something better than you were before. So the only real mistake that we make is the one from which we learn nothing. Thank you.
Thank you, Ragi. Next is by Dr. Sunita Kuriakos on the topic getting the right patient for your first case.
Good morning, everyone. So today I'm here to discuss how to get the right patient for your first case. So basic aim of your surgery is a safe surgery and more than a perfect surgery. So we do not want to get concerned about the visual outcome. We should always be ready to learn, unlearn and relearn whatever we are doing. And always stick to the point that you have to go by the book. Never miss or skip a step. History and systemic examination are very important when you choose your first patient. Slide. Okay. So history and systemic examination are always key when you choose your first patient. Always select a very cooperative patient. My sir always told me, when you are conversing with a patient, if you are speaking more and the patient is listening, that means the patient is cooperative. If the patient keeps on talking more and you are listening, that means the patient is not cooperative. And choose someone between the age between 50 to 55. This is the ideal case, because less than 45 age people are more apprehensive and more than 60 turn to be a more harder cataract. And select someone with a non-demanding job. Maybe you can go for a free surgery patient, probably a housewife female. Now always select someone who can handle a prolonged surgery. You are a beginner, so it will take almost 30 to 40 minutes to finish your surgery. So avoid people with uncontrolled diabetes, hypertension, any coronary artery diseases, people on anticoagulants, any patient with psychiatric history, people with on tablets like tamsulosin, which will have floppy iris. And always rule out local infections. Look at the lids properly, the tooth, and diabetic people will always have foot ulcers that we skip. And you should make sure that the patient can maintain a supine position. Now, how do we make sure? When we do a pre-op A scan, make the patient lie down, do it under a drape. So we can always find out people who are symptomatically asthmatic, people who are claustrophobic, people with scoliosis who can't lie down, and people who have severe head nodding. And always lying down will also help you assess the anterior chamber depth. Then take a detailed ocular history. We should always avoid one-eyed patients, especially people with vision which are very low, less than 3/60 in the other eye. And if there has been any history of trauma, any previous surgical history in the same eye, like any VR surgeries, glaucoma, or any corneal surgeries. Patient with recurrent uveitis, high myopes, high hypermetropes, high astigmatism, these are all difficult to do. And people with complicated cataract, that is secondary to trauma or any iritis. And always do a detailed examination of the fellow eye. Always study the surgical note if that eye has been operated. If there is any iris chafing, if any PCA has occurred, if there are serious other intraocular complications like dialysis, any iris prolapse, and see what type of IOL has been implanted. If it is a 3-piece, an iris claw, or anterior chamber IOL, so you know it was a difficult surgery. And always do a proper adnexal examination. Check the ducts for patency, check if the intraocular pressure is normal, see if the sockets are deep or if the severe frontal bossing. So this will hinder your access to the globe when you are sitting superiorly. Check for lid swellings. Always evert and look for swellings. Check for blepharitis. Meibomian gland dysfunction will have severe secretion when we put the speculum. Make sure you flush it properly before you start your surgery. A detailed dilated slit lamp examination is also important. Look for any corneal scars or severe corneal dry eye. Look for any shallow anterior chambers in which post-YAG PI patients, patient with pseudo-exfoliation, non-dilating pupil, posterior synechiae, any floppy iris should all be avoided. Cataract also, make sure to choose not a very soft or not a very hard cataract. Check for phacodonis. We have to always check for it. And avoid a posterior polar cataract. Always ensure a good local anesthesia. A well soft anesthetized eye is always very important for a good surgery. So always wait for 20 minutes after you have given your block. A good drape should be put. Avoid tight lid speculums. The microscope settings, as already explained, should be checked beforehand itself. You should know your IPD very much. Should know your instruments well, whether they are sharp, how to hold them, and keep ready all those needed to manage if any complication occurs, like your vanas, iris repositas, sutures, vitrectors. And keep talking to your patient. Just keep telling them, see, I've finished this step. Now I've took out the cataract. Now I'll put the lens. This will help you also to relax. Also, the patient will also relax. And as I said, always go by the book. Do not skip any step. And always stay in your capsule. Make an adequate size capsulorhexis. And always follow a single mentor. Don't listen to many people and follow everyone. And like already explained in detail, video record your surgery, which will help you in correcting yourself. And always keep help handy. Make sure that your mentor is nearby. They are checking on you. And do not hesitate to stop and withdraw if things go wrong. So this is your ideal first case, aged between 50 to 55, no history of trauma, and all the points already mentioned. Thank you.
Thank you, Sunita, for your wonderful presentation.
I hope this IC will add on to more values and tips for the beginning surgeons. So here we are going to conclude our session. Thank you.